Hello and good morning and welcome to you all. I hope you are well fed and rested after last night. Thank you very much for joining our workshop this morning, which is about accelerating progress towards universal health coverage by closing the gap on cancer care. I'm Alison Cox. I'm the Director for Policy and Advocacy at the Non-Communicable Disease Alliance, the NCD Alliance, and I also spent 8 years working for Cancer Research UK, so this is a topic dear to my heart. And in addition to hearing from the expert panel here, who I'm going to introduce you to in just a minute, I just want to say we really want to have a good moment to engage with the audience after we've done the panel's round of questions. So please be thinking about questions that you'd like to bring or comments you want to bring to this discussion. So first of all, then, to introduce our expert speakers today. First of all, we have Dr. Najat Mokhtar, who is the Deputy Director General of the International Atomic Energy Agency, and she's responsible for nuclear sciences and applications. We have Dr. Svetlana Axelrod, who is the Director for the Global Non-Communicable Disease Platform at the WHO. We have Dr. Rispa Walumbi, who is a Health and Policy Advisor at the AMREF Health Africa, and brings a really strong civil society and regional voice to our discussion today. And at short notice and with our great gratitude, we have Dr. Okti Palupi, who is the CEO of the Bunda Harapan Kita Jakarta Hospital in Indonesia. And then finally, we have Michael Oberreiter, who is the Head of Global Access at Roche. So welcome to our panel. I'm sorry to say, and I should say versus what's in the printed programme, unfortunately, Her Excellency, the First Lady of Namibia and the Minister of Health from Indonesia were unfortunately not able to join us here today, but we have so much expertise on this panel that I have no doubt we're going to have a really interesting conversation on this vital topic. So let's get started with just a little bit of positioning and some harsh facts. According to the WHO, approximately half the world's population still lacks access to essential health services, and about 100 million people are pushed into extreme poverty each year because of catastrophic out-of-pocket spending on health costs. 10 million cancer deaths are incurred worldwide each year, and by 2030, it's estimated 3/4 of all these cancer deaths will occur in low and middle income countries. So I think it's fair to say that all of us here on the panel share one goal, which is to try and take action on this and change that and help meet the targets. And the important target to bear in mind is the SDG target 3.8, which means establishing universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. At the first high-level meeting on UHCs in 2019, they set a target for an additional 1 billion people to be covered by UHC by 2025. So before I ask our speakers for their views on this topic, I just wanted to do a quick vox pops from you in the audience, thinking about those targets of providing UHC by 2030. Could I get just a very quick show of hands from the audience on whether or not you think we're on track to achieve those UHC targets? Are we on track? No, I see shaking heads. For those of you watching at home or in your office, I'm not seeing any hands go up at all, which is worrying. And that's why it's so vital that we have this conversation. So just to get started, I just want to ask the panel, just very, very quickly, you saw the heads shaking there. Can you offer us any signs of hope? Things that you would offer that might give us hope? Najat, you just have to press the green button. Yeah,
thank you. Very good morning to all of you, and thank you. Yes, that's a good start. And I mean, we have to be optimistic, because not being optimistic, we want progress.
Mm-hmm.
And there is a will. We see that there is a will. We need to. This is very important. Universal health coverage. And if you look at my fellow panelists around here. We have UN organization, we have private sector, we have academia, hospitals, NGOs. So that means we are all here because we care. We want to move forward.
Yep.
We have a lot of work to be done ahead. COVID-19 set us back, so we need to move fast. And we need finance, knowing that, as you have really mentioned, that 70%, more than 75% of the low and middle income countries, debt in low and middle income countries is from NCDs. And yet the development finance is 2%, very little. So we need more. I'll stop here.
Thank you. So so signs for hope and signs for concern. Svetlana, any sign of hope or reasons for optimism from your perspective?
Thank you. And good morning to all our audience and the panelists. It's a great pleasure to be here. And it's really, I want to say that we should be optimistic. We are, as a doctor, I always see the positive diagnosis and other things. But look into this SDG 3.8. I want to highlight it with the SDG 3.5 on the NCDs, to reducing by 1/3 the mortality of NCDs. And we are also not on track. But we are looking optimistic, and we are looking for the efforts that we can do. And we've done a number of political meetings, high-level political meetings. We were participating in the political meetings 3 that we already had during the UN General Assembly for NCDs, 1 for the UHC. So we are raising our efforts to the high-level politicians to make their efforts to achieve these targets. But it was, of course, it's a very difficult way, and we have to focus, we have to join our efforts. We should do it with different stakeholders, how we can get the good progress. But we are optimistic.
That's great.
Thanks.
Thank you. So we've got a view that we're cross-sectoral engagement and discussion. We've got high-level meetings and high-level commitment and dialogue. Rispa, from your perspective, what sign of hope can you give us?
I think I've been accused several times of being a hopeless optimistic, regardless of the difficult times that you continue to face as a world. But I think for me, I continue to maintain my optimism despite being, wearing my other hat of a health economist. The people who look at the numbers and the money, it's very easy for us to be pessimistic, because when you look at the challenges that a lot of African countries experience, it's very difficult to mobilize resources, just given the limited resource envelope, right? But I still have optimism because I have seen, across the continent, the political will that a lot of countries have. And I think COVID-19, just the pandemic over the past few years, has, even galvanize that optimism further, because the political will has just, soared. There's more conversations on the continent about healthcare, and healthcare has become a priority, and it's no longer seen as, an expense. It's more seen as an investment. And I think that's a sign for optimism already for me. And I think now is just the time to leverage that for all of us in the room, especially for technocrats, to be able to figure out how to use that and leverage that to our advantage.
That's a great point from the economist's point of view, that this isn't a cost, it's an investment, and focusing on that return on investment. Okti, from your view, you're very much engaged in providing health services in a large hospital. What's your perspective on this?
I agree. There's to be optimistic also. Now in Indonesia is running one of the world's largest universal health insurance scheme we call BPJS Kesehatan, covering nearly 90% of 271 million population in Indonesia. So while high insurance coverage has provided financial protection to most Indonesians from catastrophic health expenditure, we are still facing challenges with access to quality healthcare. To overcome some these challenges, in Indonesia is currently transforming in its healthcare system. The first is health promoting strengthening using life cycle approach to improve awareness on healthy life cycle as part of the early prevention program. Then the second is we revitalize a preventive function in primary healthcare. Among many, the effort-compassing expanding routine immunization, including HPV vaccine and screening for highest cause of death, including lung, breast cancer, cervical, and colorectal cancer. And the third is we initiate referral network program to aim to distribute competency of service among the hospital.
Fantastic. So you're looking at this extension, not just care, but also health promotion and longer view, the broader view of health treatment. That's great. Michael, from Roche, from the private sector perspective, can you also offer us some things that we should be focusing on?
Yeah, I'm a little bit torn here. So on the one hand, I'm an Austrian, so I'm genetically programmed to be overly optimistic. On the other hand, I'm an economist and I have to follow and look at the data and the science. I think we've become extremely good in treating symptoms. I think there is some progress to make addressing root causes. And I think we need to dramatically accelerate. So I think we have fantastic solutions from people on the ground, but we're still struggling with scalability. And if I look in this room, we're a little bit preaching to the choir. Because what you said about like health as an investment, I think everyone in global health acknowledges that. But like, how do we get the finance minister to acknowledge that? How does it get reflected in a country's national budget that, you know, this super cool concept 10 years ago, health in all policies. So I'm not overly optimistic, but I think absolutely we need to proceed. There's no alternative to universal health coverage.
Fantastic. And I think that's a really important point, this view of broadening this out, so that health isn't just something to do with the health service, it's right across, both in terms of contribution to improving health, but also the return on the investment to the economy as well of improvements in health. Fantastic. Well, thank you very much for those opening remarks that kind of set the scene for the discussion now. And I think, as you say, there's a UN high-level meeting, the second one on universal health coverage coming up next year in September in 2023. And hopefully the discussion we're going to have this morning will help tee up some of the really important themes that we need to be addressing as we build up to that meeting next year and try and see how that can help us get on track and improve our optimism about reaching those targets. So I'm going to do 2 rounds of questions to the panel, and then I'm going to open it up to you for questions and discussion. So I'm going to start off with Svetlana, from the perspective of the WHO, looking back at the commitments made in 2019 at that first high-level meeting on UHC. Are health systems ready to incorporate the specific needs of NCDs in their national UHC packages? Do you see any sort of trends in how NCD services are currently being included into UHC? Svetlana, and I'll give you 5 minutes and I'll give you a little nod when we get to 3.
Thank you very much. I will try to be really brief and to focus on the important points that I want to mention in my intervention. Yes, you said about the high-level meetings, and I first of all highlighted it is very important to engage the high-level politicians for their decision-making in the countries, in their countries, how we should work together and achieve these targets. And if we are looking for the perspective of the achieving these UHC targets, it's also very important to align with NCDs. The NCD is the biggest killer in the world, and you know all these numbers and data. And as I said, we have already had the number of the high-level political meetings in 2011, 2014, 2018 for the NCDs. And all of these give us the chance to get this information to the high-level politicians to get their implementation of the political declaration that was adopted by the head of the states. So we are now on preparing the next high-level meeting for the NCDs for 2025. And we have to implement it in the countries to do the number of packages. And the package which is already is prepared by the WHO, we call it best buys. This is the tools that could be implemented in the countries to help the national policy to achieve and to reduce the mortality. But when we are saying about the NCDs, and we are saying it is under the umbrella of the universal health coverage, we have to look broadly. We have not only focus on the treatment, we also have to focus on the prevention of non-communicable diseases. We also have to think about the rehabilitation, palliative care. So it is the number of medical services that should be under the umbrella of the universal health coverage. And we have to find the synergies that is very important. Speaking about the NCDs, of course, we have to focus on the prevention. And there is the number of the risk factors that we know is very important to be focused on. The tobacco, the reducing of harmful use of alcohol, and physical activity, healthy diet, and also environment. So that is the number of interventions where we can use the package of the best buys to do the national policy helpful to reduce the NCDs and mental health. So the important point that I want also to emphasize in this my first round of intervention is that we should do it jointly. It's not should be only the government. It should be also the multi-sectoral approach and partnership. The partnership is very important. And here we see the panelists who are showing this partnership. We have the UN agencies, we have the private sector, civil society, academia. Only jointly we can do this work. And that is the critical important point that we have to do. WHO is working with the different partners. And really we have a lot of good progress where we can use the voice of civil society, working closely with the private sector. Sometimes it's very sensitive working with the private sector, but we do our best to find the good ways of collaboration. And we have the number of tools how we should engage with the private sector. So let me stop here and to give the floor for our other panelists to say a couple of words. Thank you.
Thank you, Svetlana. And so you're sort of drawing out this view, not just treatment, but also prevention through to rehabilitation, and also this idea of a multi-sectoral approach and partnerships. So Najat, I'm going to come to you next. The IAEA, my assumption is you're mainly focusing on cancer care, but you were saying this morning also across the pathway of prevention and diagnosis. And we know that not all patients everywhere are able to access the care that they need. So can you tell us a bit more about the social, cultural and economic determinants that prevent those from the underserved populations from accessing quality and appropriate cancer services, and how IEA as a science-based organization incorporates that kind of social and political science thinking into your strategy?
Thank you. Yes, I think you started by, the work of the agency, and I think many colleagues here in the audience, they know the agency through the news, through the war going on, or through the Iranian, but maybe some of you, they don't know that we are having a big program on human health and particularly radiation medicine. And as you have rightly said, that when you look at radiation medicine, for example, and we know that we need one CT or PET scan by 1 million of the population. And when we think of countries, particularly low and middle developed countries where there is no nuclear medicine facilities, and when you think also of radiotherapy, and you think of more than 30 countries worldwide, they have no radiotherapy facilities. And why also you think as medical doctor that cancer, 50% of cancer patients, they need radiotherapy. And particularly during COVID-19, diagnosis services were very limited and even went by 50%. We did the survey. So that means that people that they had early stage cancer, now they are, the cancer stage is advancing, which means they need more radiation medicine and radiotherapy treatment. And that's why at the IAEA, we needed to have a collaborative work. We need to have action And our Director General launched at the African Union an initiative called Rays of Hope, where we are calling of partnership to really give access to those to disadvantaged population, those that they don't have access. And this is work with the member state, with the other UN organization like here with WHO and NGOs, and to really work together how we can give. It's not only about machines, it's about capacity building. We need nurses, radiation nurses, we need the technician, we need medical doctors, we need care in general. And we need sustainability as well, because you can't put radiation medicine or cancer treatment facility in each and every country. So we need to think about innovative methods like regional centers or sub-regional centers. We need also to do research to advance how we can optimize what we have. So I think this is an opportunity where we need to team up to give access. Of course, there is financial part, how to cover, which is part of the universal health coverage, how we can finance that. But I think this is thinking of upscaling, of giving access to those in remote countries that they don't, remote regions, but also it's teaming up, and it's about also sustainability. I stop here and maybe.
Could I just ask you a little bit more about
Yeah,
the
sure.
Rays of Hope program? Can you just tell us a little bit more about that?
I mean, I have brochures here if needed. Rays of Hope is as I said, is an initiative that calls a partnership, teaming up with countries to really scaling up and give access to radiation medicine to each and every one. And here, a commitment of the country is in the center, is core. Without that commitment, you cannot move. As you have rightly said, countries now, we are having a war, we are having an inflation, climate change. So we need to talk to finance minister and others. So how to really sensitize the country that cancer is important and it's investment. If you invest in cancer treatment, you have a return. So this is Rays of Hope. It's giving not only machines, but training, long-term radiation oncologists, nuclear medicine physicists, medical physicists, nurses, technicians, and also having these centers, what we call anchor centers, where you can provide help to those that they don't have access. So this is in a nutshell. I don't know if I give. Thank you.
Well, thank you for that. And, you know, it is shocking figures. As you say, you know, if 50% of cancer patients need access to radiotherapy or nuclear medicines, and yet there are countries where there's absolutely no access, this is clearly a long way away from universal health coverage and the principles thereof. So I'm good to hear about the Rays of Hope program and that broader view, not just machines, but workforce, systems, regional collaboration. Thank you for that. But building on that, on this issue of access and inequality of access, I'm going to come to you. You've worked extensively in rural and low-income urban areas, and given the diverse challenges to equitable access, geographic, socioeconomic, institutional, cultural, just to name a few, how can universal health coverage policies be designed for equitable reach, to reach all people, particularly those in marginalized groups? And I'm going to come on a little bit to talk about out-of-pocket expenses as well. So yeah, how can they be designed? What can we do better given all those challenges?
Thank you for the opportunity to kind of share my perspective, given what we've managed to do, not only as AMREF, but just who we work with, because we have an extensive network. We don't work alone. We work with government, we work with private sector, we work with all of these different people, academia, even WHO, for instance. And I think it's really important for us to understand that policy is actually a long game. And we have to learn how to play that long game, because during that time, it's also important for us to make sure that you encourage each other, especially because it's going to be hard. And it's mixed with politics, right? And politics in itself is a mix of a short and long game. And you have to make that balance. So as a policy advisor, I sit and I try to figure out how to balance this policy long game and the politics, to be able to sell a dream. And I think one of the things that's important for us to do is firstly understand just the context that we're operating in. And when you look at the African context, you have, the design of our health systems, were based in colonial legacies, right? And that made these systems that we have now very unresponsive. And because they're unresponsive, that means people are not accessing this care in an effective way. And that means that there's very low ownership of this health system. And when there's low ownership of this health system, that means you're not improving health-seeking behavior. You're not focusing on the demand. And that in itself is a waste of resources because you've put up all these facilities and people are not accessing them. And so that's one of the contextual things to have as an underlying frame. The other thing that's important is also just how we look at our revenue generation models. When you look at, again, the African context, there's a challenge we have on modeling the high income country model of revenue generation. And unfortunately, within the African context, again, we have a highly informal economy. So how do you make those balances between these challenges with how we've designed the health system and also the challenge we have with how to generate revenue, sufficient revenue to make these investments? So given that context, the next move is then to go on to then what do we do with this information? How do we design these policies that are more effective, are cognizant of this context? And I think the first step we have is to look at what does success look like, right, in the long term, and then pick out what small but strategic investment we can make for now. Primary healthcare poses a really important investment, right? And as we talked, I think a couple of the panelists have talked about the life cycle of treatment. That life cycle starts at the primary healthcare facility. So how do you make sure that, we've defined this version of success and we've looked at how to progressively and sustainably, make that as a priority in our interventions, whatever the interventions may be. And then I think also another thing that's important to do is also to have a need for continuous self-evaluation, just for countries. It's okay for you to say that maybe this wasn't working. It's okay to say that. It's worse if you keep doing the wrong thing, right? So if we have this habit of going into self-evaluation and evaluating what we've done together, right? Even from the perspective of civil society, it's not even in a combative way. It's more to sit down on the table, just as we're sitting now, and figure out what are these things that we can do given what we're seeing as the challenges. And then I think if we can do that in a multi-sectoral approach, and I mean not just within healthcare, I mean, we've talked about health in all policies, and I think that's such an important point because that is an indicator. Why can't health be an indicator of success for an entire country? If it was an indicator of failure during COVID-19, why can't it be an indicator of success? So I'll just stop there. Yeah.
That's fantastic, Rispa. Thank you so much for bringing that real sort of reality check about health systems and needing to be built context specific, and what's works in one country and one region does not necessarily work in others, and particularly for bringing out that point about primary health care. So important to universal health coverage as a foundation. And I like that idea of self-evaluation as being an important part of a sort of iterative cycle for development. So thank you for that. Opti, I'm going to move to you now. You're the CEO of a major government tertiary hospital in Jakarta. So I'm going to ask you, first of all, about what are the care gaps you're seeing in your work and how we can close them. But also I want to ask you to draw on your experience because in a previous role, you contributed to the development of the National Cancer Control Programme and the development of a cancer centre network to improve access to cancer treatment. So if you could also bring your learnings in from that time, so both from your experience in the tertiary hospital and in that design of a cancer control programme, what's the role for UHC in helping to deliver all this?
Thank you. There are several challenges to improve cancer center in Indonesia. First, resource barriers. In Indonesia, cancer centers are available only in large-scale hospitals, usually in big cities. Shortage of oncologists and medical equipment causing poor cancer services. And then the second, about educational barrier. This is cause low awareness and source of information for the patient. And then third, late diagnostic. Many patients come to the hospital in the late stage, creating lower chance of cure. About 70% patients come to the hospital in stage 3 or 4. This situation largely due to delay in patients seeking medical help, which lead to delay in diagnostic and treatment of cancer. In 2021, the Minister of Health of Indonesia was launched a health system transformation program, which cancer is one of the priority disease. Cancer control efforts are strengthened in all levels of care, including promotive effort through the cancer education, prevention through cervical cancer vaccination program, early detection program for cancer downstaging, especially for breast cancer, cervical cancer, lung cancer, and colorectal cancer, as well as effort to improve quality and patient access to cancer services. Addressing this barrier and achieving SDGs ambition, we believe require commitment and contribution of all healthcare stakeholders in the country. Therefore, we embark into partnership initiative, which involve academia, industry, expert, also provider. This partnership aims to accelerate the establishment of the National Cancer Center Network, which involve more than 300 cancer service providers in the country and ultimately to improve cancer care in the country of Indonesia. There's 3 key partnership that has been done and be a pilot project in Dharma East National Cancer Center in Indonesia. The first is Project ECO. Project ECO is extension for community healthcare outcomes, a telehealth mentoring to educate healthcare professionals in remote areas to treat complex disease, allowing patients to receive better care and better outcomes. Dharma is become a hub. We also collaborate with patient organization to implement the ECO model for cancer prevention and screening. And maybe next month, we are going to open a new hub in Sarjito Hospital in Yogyakarta. After the first one in Dharma East Jakarta, the second will be launched in Yogyakarta. Discussion ongoing with the Ministry of Health for the adoption of the model to the national wide. And the second project is oncology nursing capacity building. This is to address urgent needs to train nurses to provide cancer care and strengthening future oncology nursing workforce. Okay. And the third is establishing the new role for professional cancer patient navigator at the hospital and embed into the care system to support patients along the treatment journey to better outcomes. And maybe the next week, we will have the first batch of 25 students start their learning program for full year with the Tata Memorial Hospital in India.
Ah, fantastic.
Yes, we have, I have, Benita?
I've got about 30 seconds more. I'll give you a minute.
Okay.
I give you 1 minute from me.
Last.
But it's fantastic. Do keep going, please.
Okay. The important things that we need to have in such a partnership program in clear strategic to ensure the sustainability of the project. And here the role of the government become critical because it relates with program adoption and alignment with the strategic planning of the government, as well as the enactment to the policy required. Thank you.
Fantastic. Thank you so much. And you covered an awful lot of ground in that intervention. Really noticeably, you know, when you say that 70% of patients are presenting at stage 3 or 4, you're really drawing attention to the fact that only so much can be solved in hospitals, that so much needs to happen further upstream so that people are being diagnosed earlier. So thank you for drawing out that. And also great to hear about the investment and the delivery of services and the development of these hubs in Indonesia, and also bringing out again that it's not just about the hubs, but it's all about the training of workforce as well. So thank you for that. So Michael, we come to you finally on this first round. You've heard a lot from our other colleagues. I'm going to ask you a little bit about health financing to drive strengthening UHC, and how the blending of private and public financing solutions can help fill that resource gap. That's my main question, but also if you want to bring in any other reflections, please feel free.
So allow me to build on what I've heard. Because I heard a lot about like this partnership and importance of partnership model. I think we can do better. So in my world, where I'm sitting it takes me a year to get a memorandum of understanding signed, 12 months to get a signature on a piece of paper. Let's work on that. Then we already have a deal. Just think, I think in order to drive universal health coverage, it's just like we all know what constitutes a good partnership, but I think there's room for improvement in real practice. And I think we have a little bit, sorry to say that, or actually not sorry. I think what I consider one of the biggest roadblocks to UHC is really it's too much of ignorance and arrogance, and it's too little trust. And what I mean with ignorance and arrogance is that we always talk about let's tear down those silos, but they are there. And we all think, no offense taken here, but we all think we have the solution. So trust me, as being in Roche, when I worked in countries like India and Pakistan, Bangladesh, I totally learned it the hard way. What is white privilege? Like global solutions do not work in communities and on the ground around it. So when it comes to, and I come in a second to health financing, I think what you have learned is it really starts with listen to the communities, full stop. And you cannot develop a solution if the people the solution are impacted by are not sitting in the room and at the table, and if they don't have the same share of voice. And when it comes to, and here come with this private sector thing is, I think what the private sector can offer is, you spoke about like, let's share failures. We fail all the time. Like but here's the thing. If we manage to say like, because governments are by nature and by definition, they have to be risk aware because they're spending public money, right? You cannot afford to fail as a government. But if you could reframe it as, hey guys, these are learning opportunities along to find better solutions. And I think what the private sector can bring is some of the management tools that would create an environment where you can be more open with partnerships and where we can faster fail. Because I think it's about faster failing so that we eliminate those options that are not working. And it's the same principle with health financing. I think universal health coverage, and I come from a family of nurses. My mom is a nurse, retired now. My two sisters are nurses. So both of them quit during COVID because they said they cannot do it any longer. So when it comes to health financing, I think the role what the private sector can play is really being the catalyst in connecting the dots and offering our opportunities. We can do pilots, but actually this is also where we then kind of end. I think, to be honest, talking about what can we bring is, I cannot scale up, full stop. Like when it comes to scale up, we need government, we need partners. But I think in health financing, we can accelerate. And particularly for the other countries, I think we should also stop pretending like as if there's such a thing as a good European way. You cannot just develop here solutions and then ship it over and then you please implement. I think when it comes to Africa, where a lot of the backbone of the economy are people who earn like daily wages, you need a different form of financing model and it has to be blended. Because we do need solutions for patients right now, while you have an out-of-pocket market. And we know some people spend 70% of their income on treatments. And it's not only they're spending their income, they are losing income while on treatment because they cannot open up the shop. So we need some systems right now. And there are projects in place on the ground, and we need to scale them up. But I think, and I might be wrong, happy to be convinced, the long and ultimate goal around UHC has to really be this financial protection. So there needs to be some sort of public funding, not necessarily government funding, because I make a question mark, but like, how do we create a fiscal space that there's a baseline funding, which you can combine with out of pocket? But we just know from the data, you need a blended mix of finance tool. And this is like where we actually do have experience, where we work with insurers, insurance companies, microfinancing. We worked with M-Pesa in Kenya, technology you know, how we can use fintech around it. There's actually a lot of room, because I don't think we lack money. I think we just don't have the right distribution of funds.
Yep. Thank you. And some really interesting points that you're bringing out there. First of all, we need to be quicker to set up partnerships, but we also need to be quicker to acknowledge failure and move on, which I think is good messages. And also, you know, you're reinforcing the point that RISPA made, which is, you know, we can't just cut and paste solutions from high income countries to other scenarios, particularly where there's a, you know, much greater informal economy, much more day wages and so on. So really important, interesting that you're bringing out those points from your experiences as well. And the need for blended finance, that we need. No one thing is going to provide us with a solution for financing health services. We need this sort of mix of innovative public funding, insurance schemes, financing, and so on. So I just want to come to another question that I have here for you, which is slightly different, and it will then I'll be coming to you, Okti, also on this one. It's about the role for digital health solutions. It's often put out there as this, you know, particularly since the pandemic, you know, suddenly digital health, telemedicine, and so on is a solution. Can you talk a little bit from your experience about the role of digital health solutions for those living with NCDs and how that can contribute to achieving our UHC targets? I'm going to go to Michael and then
Yeah,
to you.
I'm quick and I hand it over to you. So I think, frankly speaking, I think it's the wrong question.
Okay.
I think the question should be, what is the problem that people are having?
Mm-hmm.
And let them answer the question, and then look at what could be possible solutions. So we learned from COVID, digital can help, like echo, telehealth, telemonitoring.
Yeah.
But we know, like, digital has the power to unite, but it has also the power to divide. But like, I'm far away from being a digital native. Like, I can do a playlist on Spotify and then full stop here. So I think we have to be very careful, sort of like in over promising around. But of course, there is, particularly in Africa, we have a project, a pilot project running like around digital pathology, because you will, in order to, so if you apply digital as a tool where it works, that we can close some infrastructure barriers, then it can help. But again, it's not a solution that will work everywhere. And for sure, it cannot replace the need for healthcare workers and just like the human factor in care treatment.
Thank you. And you did bring out that really important point also about, you know, needing to put people in the center of finding solutions, not, you know, when we're thinking about this. And thank you for posing the what is the problem. And Okti, I know in Indonesia, you have ambitious goals to bring digitization into the health system to advance universal health coverage. Can you tell us a bit more about those plans and how it's working there and how it's being implemented?
Yeah, in 2021, Indonesia has successfully launched a blueprint for digital health transformation strategy 2024 to realize the digital transformation in health sector. We are currently on second year to implementation and focusing on expansion and further development in the next years. And also MOH has launched, name is Satu Sehat. Satu Sehat is a healthcare that big data platform that provides integration to ensure data interoperability of the entire healthcare ecosystem, so it can be used more widely for better outcome. And by the implementation of this, we expect to have the integrated electronic medical record that contain precise and coherent patient medical treatment record across any facilities. With integrated electronic medical record, patient can seek a treatment near their home with complete individual data, eliminating the need for repeated examination and diagnostic, hence reducing cost, of course. Mm-hmm. In this manner, health budget as well as universal health covered budget can be previously used mostly for curative treatment, can be allocated more on promotive and prevention. Thank you.
Fantastic. Thank you very much. And, you know, it's an issue for many countries. I know in the UK, they really have struggled for years getting the electronic medical records correct. So was one of the challenges. So the question was, is it to do with the privacy? But it's also the technological challenge. It's just not easy. Okay. Thank you for that. So, Rispa, I'm going to come back to you. I'm coming back along the panels. I'm afraid Najat, you start and you'll finish, so it's a long wait. Sorry for that. From your experience working with the AHAIC Commission on the state of UHC in Africa, what have you seen as some of the key ingredients and best practices for sustainable UHC programs that are also effective in addressing health inequalities broadly and cancer care more specifically? So if you can sort of pull from that experience.
Yes, and maybe we call it at AMREF, we call it AHIC, right? And of course we have the AHIC conference next year in March between 6th and 8th in Kigali. And so basically we set up a commission of global health experts from the continent, 11 global health experts who sat down together and looked at universal health coverage very broadly and generated a report that not only identified, the challenges that exist, and they divided them into broader contextual challenges and also health system supply and demand side challenges. Mm-hmm. So they outlined the challenges extremely clearly. And then, but they went on further to even identify the opportunities that we can leverage. Some of those are digital health. Some of those are leveraging the fourth industrial revolution. Some of those are even, investing in, the demographic dividend, where we have a very young continent and how to leverage that. But then beyond that, we then went into recommendations. What does this all mean? And we made recommendations not just for state actors, but also non-state actors. And we looked at both regional and national level actors and also global health actors. And I think when it came out, one of the key things that was extremely important for the commission, again, was going back to, one was recognizing they actually identified places where political will already pre-existed for universal health coverage, whether that's through a national UHC policy or UHC was included as one of the national health goals. That already gives you grounding, whether it's for civil society, private sector, to engage with government, because there's already a documentation of the process and how to engage. And then after that, reforms can be accelerated extremely fast when you have political will, because this actually now brings together all the different sectors. Because when you have that political will, especially when it comes from the highest office in the land, you are actually able to bring all these ministries together. And I think it's really important to recognize that, and how, again, looking to the, to the extremely intelligent people in the room, how do you leverage that? And it's really important for us to identify how we can sell the dream, because often we come in with a barrage of problems, right? And when you're looking at it from, I've had to sit down and actually document how to, package this information in a way that's effective for ministers and for even the president. It's extremely important for you to just pick really key asks that they can leverage, right? And I think, Rays of Hope is one of the examples where this is one thing, just look at one thing, and how do you scale it up? How do you leverage it, right? But another thing that's also really important, I think, just going back to primary healthcare, especially as a foundation, is that the report actually identified how you design effective teams at the primary healthcare level. Because you need to look at when someone is coming to a healthcare facility, you want to ensure that they have what they need when they get to the primary healthcare facility. So how do you design an effective team? And part of that team is actually involving community health workers, right? Because community health workers, even before they get to the facility, they actually come to your home. So how do you integrate that across, the spectrum of care? And those investments are really critical. And I think there's a lot of work that the WHO has done in terms of the rationale for why it's a good investment to put money into PHC, right? And I won't even belabor that. But I just wanted to unpack something about the blended financing, because this is something that the report talked about. And when you look at the blended financing model, I think one of the things that is really important is when you're looking at ministries of health and ministries of finance. Yesterday, I think it was Dr. Tedros who mentioned that, often Ministry of Health is kind of like the smaller brother or sister in the whole set of ministries. Ministry of Finance is the big guy, right? Mm-hmm. And so how do you make a happy marriage between these two? And often it's very difficult, But this is the reason it's very difficult. And we discussed this in the G20 Health and Development Partnership. And I think Indonesia has actually done quite a bit of work in terms of bringing ministers of finance and ministers of health on the table to have these discussions. The key thing that you need as health is to have consistent financing that's predictable so that you're able to plan. From the Ministry of Health perspective, it is extremely difficult to be able to mobilize resources that are inconsistent. And if they're not coming in on time, that's even further difficulty to someone who is delivering care as a healthcare worker. I've been in that experience. But another thing that's also extremely critical for us to recognize is how do you make sure that it's not only consistent, but you're also not just working with high level at ministerial level, but you're also working with Ministry of Finance officers who can even be sitting in ministries of health to discuss that. And that's where budget advocacy starts. That's actually how you increase the fiscal space for health, because the Ministry of Finance officers will explain and generate information that will be targeted for the ministries of finance. That's how you make the case, by bringing those two teams together. And that will then expand to all the other ministries as well. Thank you.
Thank you so much for that. I was so fascinated. I totally forgot to give you your 4-minute warning. Sorry on that. But you covered a lot of ground there, and I just wanted to pick out some of those points. I particularly recognize the issue about political will. You can have all the evidence in the world that a problem is sufficiently grave, it needs action, and evidence that your intervention works. But unless you've built the politics to show that it's wanted, so it's not needed, it's both needed, it's workable, but it's also wanted. I think that's a really important point. And then you also sort of brought in the importance of community health workers in effective teams. So again, it's not just about the hospital, it's all the way out to the community and community health workers. And then coming back to this issue about blended finance. It's interesting that you were talking about ministries of finance and ministers. I was really interested. I heard the health minister from Indonesia speak at the World Heart Summit, and he comes from a banking background, doesn't he? And that's really interesting. And it was interesting to see somebody from a banking background get the investment case and really understand why health is an important investment. And I particularly like the point that, you need consistent financing if you're going to plan. You need to know where it's coming from. So, surely finance ministers understand that. Oh, you'd think anyway. So let me move on, and I'm going to come back to you, Svetlana. So beyond financial protection, what does a comprehensive access to NCD services look like? In your earlier intervention, you talked about the best buys, the WHO best buys for NCDs and its implications for taking that broader view. Can you just build on that a little bit more about, comprehensive approaches to NCD services, particularly with cancer in mind?
I think it's a really very timely question that you're asking me. And I heard these interventions from our panelists, and I just want to summarize it and to say that financing is very important, but at the same time, the capacity building, the health workers are very extremely important. And that is where we have to focus on. The implementing in the countries is very important to use the all ways of communication. And that is why from the perspective of the WHO, we have a number of examples how we can help countries to do their homework, how they should catalyze their finances to work in the countries to do the national programs and the national packages. And I think the best example of this is national global coordination mechanisms. We have this coordination mechanism in the countries, which is including different sectors: Minister of Health, Minister of Education, Minister of Finance is very important. And to do this work, we have the investment cases that we can do in the countries, where we can make the economic calculation how it is important to invest. So this is the importance for understanding of the Minister of Health, and to deliver this information to the Minister of Finance, that investing in health is very helpful for the country economically. And this kind of investment cases we already did in the number of the countries, more than 22 countries. And we have different kind of investment cases. This is the investment case for the non-communicable diseases. We started working with the investment case for mental health. We have the investment case on the progress for the digital health. And this is help countries to deliver this information to the government, to the high-level officials. And this is the example how we do. Our work is focused on this also the high-level advocacy and partnership, but also we have the focus of the capacity building, and we already are developing and we are finalizing the special training course for the politicians taking a decision on the health area. We are working with the Johns Hopkins University, and it will be the first training course that we will have the pilot in some regions in Europe and in EMRO region to see how these policymakers are involved in the national policy on the NCDs. So we are finalizing, we will launch it very, very soon. And I am inviting everybody to join this course. I think it will be very helpful for the politicians, but also for the managers on NCDs. And we are also inviting young people and researchers to join this course. Yesterday, we have a very interesting ceremony of award for the young researchers. We did it with the partnership of Defeat NCDs, and the Director General was also with us. And we invited 7 young researchers to join this World Health Summit. They are with us during these days, and they are really can provide new, innovative, and fresh ideas how to invest in the NCDs, in the universal health coverage, and we want to continue this initiative. And of course, it's very interesting and very helpful.
Great,
Thank you.
Great. So good to hear about these sort of tools that WHO is developing to help make investment cases, so you can, really take on that high-level advocacy and building the case across different kinds of health services. And also interesting to hear about this course. Can people find out more about that course? Is it on the WHO site?
Yes, of course, we'll be happy to provide all the information. As I said, it will be finalized very, very soon. So at the end of October, beginning of November, we will launch it. And we have the Knowledge Action Portal. This is the interactive platform where we can provide, where you can get all the information related to the NCDs. So you just put the key KAP, Knowledge Action Portal, and then you will see all the information related to the NCDs.
Fantastic.
It's a very interactive platform where you can find about information about the best buys, about the collaboration centers. So please use it.
So that's the Knowledge Action Portal, KAP.
Yeah.
Thank you.
Thank you.
I've got one last panelist to come to, and then I'm going to be asking you, the audience, for questions, and you at home or in your office or wherever you are watching this online. So I'm going to come back to you, Najat. Again, talking about packages of essential medicines and essential treatments, what does that look like from the IAEA focus on cancer? And what would you like to see in terms of these inclusion of packages in UHC? If you could speak to that.
Thank you. We have heard that financing is important, but also using this finance wisely is also important, right? So in these packages, I also said at the beginning that 70 or 50% of the cancer patient, they need treatment, they need chemotherapy, but also radiotherapy. And we did a study, Lancet Oncology Commission, that was led by the IAEA. I think wasn't published last year, right? Was published last year. And we showed in that study, if we scale up imaging and treatment and quality care, almost 10 million deaths could be prevented by 2030. And we could also see a cost benefit return of over $2.6 trillion. So if you ask me what I want to see in this package, we need facilities for cancer treatment, not only treatment, but also diagnosis.
Mhm.
And this is not a luxury. This is needed. And this is also an investment for lives. So I would like to see safe and secure facilities on radiotherapy or radiation medicine in countries, but not only in big cities. It has to be remote. It has to be given to. We have to put the communities in the center. I'll stop here.
Yeah, perfect. Thank you. And that's a very strong figure, isn't it? Both in terms of lives, 10 million preventable death, which is extraordinary to 2030. But we've been talking about the investment. Yeah. And then the investment case, we keep talking about making the case to the finance ministries, a $1.3 trillion return.
Yeah, we need data. And those are the data.
Yeah.
They speak by themselves.
Fantastic. I said you were the last, you weren't. I'm coming back to you, Michael. One last chance. Again, great if you can respond and reflect on what you've heard, but just to tee you up, why does the cancer care ecosystem for UHC, why does it matter so much to UHC? And what do you see as a role for the private sector? You touched on it in your earlier intervention about the sort of the skills and tools that the private sector can bring. But, just talk a little bit more about effective partnership models, if you can, in terms of delivering that.
Okay, let me try to answer these questions twofold. So one is just what you said now, that it's the numbers, full stop, right? It's the numbers. Why does cancer care matter? You will not reach UHC without addressing cancer care. But I think there's also quite sort of like a very gender-specific case for cancer care, because if you look at the numbers, like women have surpassed men when it comes to lung cancer. Breast cancer is still a problem. We just know in a lot of cervical, so we know in a lot of those countries the very specific role of women when it comes not only to the family, but also to the economy. So there's, apart from cancer as a disease, if you look at the people, it's just like, it's just like a core element of also women's health that we need to address. So there is a reason there for that. And again, when it comes to partnership, I just can re-emphasize. I learned it the hard way, what is a good partnership with my partner. So I think it starts with just acknowledging sort of like, what do we want to achieve together? Like, what can I contribute? What is expected from you? Contribute and hold each other accountable. It's actually not that complicated, right? Like, but I think we're just struggling sometimes a little bit in putting the action behind it. But also we have some great examples. But I really think we need to scale up partnerships where it makes sense, because sometimes you are just faster because you know better. I also warn for, we should not create partnerships just for the sake of. So I would not collaborate with WHO just to get your logo on something that makes me feel better. I think it should be, does it drive the outcome? And I think with UHC, we have created a little bit of a monster, because there are so many aspects and facets. And I like really what you said, and what you said is about like, just listen to the people, like, and listen to the communities, because they can help us reducing complexity. And it's just like first step, and then the second step, and then the third step. We cannot tackle like all of it at once. So it's about reduction complexity, listen to the communities, use partnerships where they are useful, from my point.
Thank you. And thank you so much for bringing in that point about women's health and the burden of cancer on women. We talked about the UHC high-level meeting next year. There's also a Women Deliver Forum next year in Kigali. And I think it's really important to be bringing in also these intersections between reproductive and maternal and child health, but also, where that intersects with in a well joined up universal health coverage system with other aspects of women's health, and how we can be using those moments of interaction across, for example, maternal health to do screening, to respond to other aspects of women's health, including cancer screening, diabetes screening, and so on. So thanks for bringing that up. And also, again, it's been a common theme about the partnership. It's about putting the people first into that and understanding the communities that they're working in, and how to make partnerships based on something that makes sense rather than just looks good or is a PR exercise. So I'm going to open this up to the floor now. Oh, it's great to see at least one hand going up too. Brilliant. Fantastic. We've got a really excited audience. So I'm going to take 3 questions first, and then I'll open it up. So there's that gentleman there, I recognise you. Took the next question, and I think there was a lady there at the back, so we'll take those first. So over to you, if you please do, and feel free to introduce yourself as you ask your question. And if I can ask you all to ask questions rather than long statements, I'd really appreciate it.
All right. Is this on? Yeah. Okay. Good morning. My name is Tobias Binder. I work for GIZ, German Development Corporation.
I don't know. Can we? It's okay. Keep talking.
All right. Maybe I'll just try to have a loud voice then. I work for German Development Corporation on vaccines, but I want to ask my questions more as with my the head-on of having been a researcher also on access programs. And one of my research projects was also specifically on access to NCD treatments. And here I would love to ask, maybe WHO could answer this. How can you actually improve the access to treatments in the countries? What do you recommend to countries? Because of course, even though maybe prevention is more cost effective, many of the patients and also many of the politicians love to actually provide access to treatments. And at the moment, from my research, I saw that most countries relied on, or especially the LMICs that I spoke with, they relied on what the industry offered in terms of access programs. But if you look on how you can really get the cost down with respect to introducing biosimilars, etc., I would love to understand and how far work's being done around that at the moment.
Thank you. So I'll just open that question first while we pass the mic over to the gentleman there. So the question there directed towards the WHO, but I'm sure others have thoughts on this. How do we go about improving access to treatment? Prevention, as you say, politicians don't like proving a negative, what they've stopped from happening, but they love to show what they've actually done in terms of counting numbers. I mean, so Svetlana, can you say anything about that?
Yes, I think it's a very important question, and I will be happy to get involved and to get more about your research. It will be very interesting to see in which area of NCDs did you do your research on the access to the treatment, because there is different non-communicable diseases. It could be the cancer, it could be diabetes, it could be the chronic lung diseases. Yeah. So when we are speaking about the cancer, yes, it's very important to get the best technologies that we can, and that is maybe our colleague from the Roche could provide this more information. But it's important also to focus and that access to the treatment will be in the low and middle income countries, because sometimes it's a very big gap between these countries and how they can get the treatment. And our colleague from the ERAU already said that it is very difficult to get the best technologies to treat the cancer. So what the WHO can do, we can just to support countries to do their national efforts to get the treatment for the cancer and rehabilitation of the cancer. And of course, we couldn't buy this treatment. We just could provide the tools how the countries could communicate with the private sector, or how they should do their national cancer programs. And that is the way where we can support as the WHO to make this universal health coverage, health for all, as we say it, but we couldn't deliver the treatment. If we are speaking about the diabetes, it's another story. And this is the access to the insulin, but it's not today that discussion.
Okay, thank you. Najat, do you want to come in on this?
Quickly, as far as radiotherapies or radiation medicine is concerned, we need 5,500 machines, particularly in low and middle income countries, to give access to poor population to give access. So we need financing, we need funding to give, and this is what Rays of Hope is about, is to team up, call up upon private sector, communities, NGOs, and other UN organizations to team up. And with the country, this is also, we're talking about finance ministers. We need to prioritize. This is important because if 75% of debt is about NCDs. So we have to do something about it, and it's investment.
Thank you. I'm going to take some more questions. I'm sure there's a lot more that could be said on that one, but we're going to move over to your question over there.
Thank you very much. My name is Jörg Heyer. I am the CEO of the Comprehensive Cancer Center here in the Hannover Medical School. And actually, it's my privilege to very closely work together with the new BPJS insurance. And I analyzed together with Okti and some other colleagues, I analyzed the initial cancer care processes. And this is actually what I want to draw the attention. And radio oncology is a very good example for it. We just don't need to focus, no doubt, it's capacity building means, of course, resources, building resources, but also means establishment of processes. And this is one of the key lessons that we learned, and the economists will surely agree that if we put resources, if we make an investment, we have to ensure the usage as efficient as possible. And for these things, we need numbers, of course. This is what I had the privilege to do, but we also need expertise and competences to do these things. And so this is actually an approach to build up, and my question is towards more or less WHO, to build up competences and to provide tools rather than solutions to organize healthcare management, not just in a single hospital, but the entire supply chain and the entire management. And this is something where most of the countries that I know, especially the low and middle income countries, have severe shortages.
So your question was?
If the WHO has such programs to support these things, or if you are planning these things.
So.
Today, I am a star of the answering the questions. So from the perspective of the WHO, we are working now, and especially the department that I am leading, Global NCD Platform, to develop a tool how the member states should engage with the private sector. And this is also an important part of the work that we have with the partners to show how these dialogues should be designed, and what is the challenges, what is the risk factors, and what is the opportunities also for this engagement with the private sector. And we are finalizing this tool. It will be very, very finalized very soon. We did a number of the meetings in the countries to see how what is the specific areas of work. And that is also answering your question, what we are doing. We are find the ways how to communicate with the private sector, how the companies could support national government to deliver the access to the medicines, to the treatment, and that is the under the development. So we have the group of partners who are giving us the inputs to create this tool. So it will be finalized hopefully in the early beginning of the next year, and we will also present it to the attention of our colleagues and partners.
Great.
Can I make one comment, Svetlana?
Please.
It's fantastic, and I really love the WHO tools. I use your investment case tool with my internal discussions. I think the next step would be amazing if you would consider, or I could recommend for the topic, for example, like you. So I do have, or we do have, like I have process managers. God knows I understand 50% what they're doing, but like I have people who can design very complex systems very efficiently with minimal use of technology. So if you would consider, could recommend your partners, like just involve private sometimes when it comes to the problem statement already, because I think it might help to change the problem statement that you just make. And then we could, I think then we could accelerate progress in that space.
Okay, thank you for that, and for that encouragement to WHO. But also, it's an interesting point. We've all been saying, this cut and paste approach is difficult, but can we still find tools that can be adaptable enough for different settings, and use agile thinking around that? I'm going to. Sure, yeah, go ahead, and then we'll move on.
Just that we do, I don't know, Svetlana, what's with your team, that we have these impact missions. That we organize with WHO, IARC, also with some experts worldwide, where we go to a country, we work with the country to really map the ground and see what's going on there and what we need in terms not only about equipment, but about capacity building.
Great, thank you. I'm going to take this question and then I'll also take another question at the back and then we'll do a final round because I'm conscious of time. Over to you.
Thank you and congratulations to all the speakers. I'm Elizabeth McIntyre from Université Paris-Cité in Paris, France, but I'm here as president of the European Hematology Association and president-elect of the Biomedical Alliance in Europe. I'm a medical doctor. I'm a hematologist. We do a lot of cancer care, 10% of cancers, blood cancers, and we use a lot of innovative, expensive therapies and a lot of innovative diagnostics. And in all this multi-stakeholder discussions, I quite understand that governments have to be risk adverse, but cancer care sometimes goes wrong. And I'd like to ask, why is the medical profession not sat at the table as well? Because it's always a question of who takes the responsibility when something goes wrong. Mm-hmm. When the diagnosis is inappropriate, when the mutation is not detected, when the radiotherapy has a problem, when the chemotherapy or the surgery has a problem. Mm-hmm. And I think it would be nice to see the medical profession at the table as well. Thank you.
Okay, thank you. And interesting, we do have some people, people on the panel have experience in the health profession and certainly see. Yeah.
Public health is there.
Yeah.
But it's getting increasingly difficult for public health to recognize a very specialized environment.
Yeah, and I'll come to your question, and I'm looking to who would like to respond to this. I mean, maybe Okti. This issue about liability, we've been talking about the gap in care, the problem that not enough people are getting care. This is a slightly different problem when they get care and things go wrong. Thoughts on that?
Yeah, it happened also in Indonesia that the lack because of Indonesia is archipelago, so the lack of access to good health is very difficult. So that's I agree with this.
Yeah. Mm-hmm. Any other thoughts on liability? Yeah.
I just want to add, it's very interesting to have this interactive discussion, and thanks very much for raising this important issue. Mm-hmm. What I want to say that from, again, what we are doing, we have a special initiative, people living with NCDs, and we are inviting these people who have this their own experience with living with NCDs, with the cancer also, where they can provide us the information about how they feel, how they get the rehabilitation, palliative care. And we've got this information from all the regions of the WHO, and we are also developing a tool how we should engage with the people living with NCDs. So it's important that you mentioned this point from the perspective of the Association of the Doctors, but also it's very important to get the voice of the people who are suffering from cancer. And we are highly involved them in our discussion. We are listening what is happening in their countries to avoid any kind of stigma. So that's this is very good that you pointed, and I want to also to highlight that involving the people living with NCDs is very important for our work in the WHO. Thank you.
Thank you. There's a lady at the back. That's the mic.
It was an excellent discussion. I'm Dr. Shanta Kumari, gynecologist. I'm the treasurer of FIGO, the International Federation of Obstetrics and Gynecology. We have our presence is in 131 countries, and I happen to be the president of FOXY, the Federation of Indian Gynec Society. What we find is a cancer cervix is a huge burden. That's what we are trying to advocate the HPV vaccination, and especially like in the Southeast Asian countries like India, Pakistan and all. We do understand that, yes, treatment is one part, but I think HPV vaccination is so very important that it has to be added in the national immunization programs. I think that is very important, and unless there's a political will and when there is a voice and a strong message from the organizations like WHO and FIGO and FOXY, I think then only we'll be able to make a difference. This is very important, accelerating action. We know WHO is doing it, but I think after this World Health Summit, to send back a message that this is what we believe, I think will make a difference.
Thank you so much for bringing up that really important point about cervical cancer. We know the WHO has a target for elimination of cervical cancer, and it's only through rollout of vaccination, amongst other things, that we're going to see a difference. So thank you for bringing that in, and also speaking to that point about women's health that came up earlier. I think we've got time for one more question. I'm going to take that lady over there. I'm so sorry. I'm going to take. Just maybe I can take two very quick questions and then we'll wrap up. Yeah.
Hello, my name is Rasha Shrede. I'm a research specialist at the Cancer Control Office in King Hussein Cancer Center, and I'm speaking on behalf of the International Pharmaceutical Students Federation. I would like to thank you for the great discussion you've put up in UHC for cancer patients. I guess I want to learn from your experience and comments about specializing specific strategies specific to countries. And I want to know what your advice is about resources and resources and strategies and tools that we can utilize to increase survivorship care to cancer patients beyond the treatment, because they deal with side effects and they live their life after cancer and after the treatment, the primary treatment, especially in like low and middle income countries, because the focus mostly is on the treatment and not beyond the treatment. And I want to learn from your experience about the tools and strategies that we can utilize.
Thank you very much. Great. So that we've had questions about prevention, but this one's about survivorship. Anybody want to speak up? Rispa?
So I think one of the things that's really important that's worked in, like the context that, you're talking about is really important for us to, again, go back to that model for primary healthcare, right? Remember, primary healthcare is not just about the prevention part. It's also after the patient has left the facility, they go home, right? And you need a point of care for that patient for the long haul. And this is a combination of where you have to look at a design for a primary healthcare system that has a really clear connection between service at the primary care level, how you refer this patient through secondary to tertiary level, and then how you refer the patient back down, right, to the primary care level. And that's going to involve a lot of important care. You have examples where community health workers have been responsible for guiding people through their treatment after care, right? To talking to them about nutrition, talking to them about their care, even for diabetes patients, talking to them about, diabetic foot care and things like that, right? And it's not to say that you're taking over like some of the responsibilities that are held by healthcare workers, other healthcare workers, but it's about making sure that the team is comprehensive enough at the primary care level so that you're delivering care holistically. That's going to look at a whole spectrum of care. And that's going to be really important for making sure that you're really looking at people-centered care. That's what people-centered care really is. It's really about tailoring it to what this person needs. If this person needs longer term care, don't make them go to a facility that's so many like kilometers away. How do you refer down even the drugs that they need, right, in a more effective manner? So I would just, again, I know I've talked about primary healthcare quite a bit, but it's because it's such a value proposition for universal health coverage because of how it can accelerate cancer care, long-term care for hypertension, diabetes, and all these other ailments that people suffer from.
Would you allow
Brilliant.
one comment?
Of course.
So for personal reasons, I'm super interested in the topic, and thank you for doing the research. Don't look in the healthcare system in a traditional one. There's not a single healthcare system in the world that provides efficient post-cancer treatment care. But where you can find a lot of information, anecdotal evidence, and data is actually among patient organizations. So more than happy to connect you with some, but they are very strong, highly professional patient organizations, and they really have a lot of data. What they don't have is a researcher who is asking the right question. So
Thank you so much. And look, I'm really sorry, there are hands I've not been able to take for questions, so apologies for that, but just mindful of time. I just wanted to give the panel just one last opportunity to leave the audience with some final thoughts, something, a takeaway that you'd like to leave everybody with to think about, particularly looking forward to the next high-level meeting next year. I guess I'll go back down the panel. So Najat.
Thank you. It was a lovely session, really very interesting. And I think what I heard also from my colleagues, partnership is very important. So we need to work together and not and particularly knowing what the other is doing. We have to complement each other, not to repeat. So, because we don't have time to repeat, we have to complement. And the second point, if I may, is mainly to put the communities and people at the center. They have to be in the table, around the table, also having their voice to be heard.
Perfect, thank you. Svetlana, last thought from you.
I would like to say that it was a great pleasure for me to have a discussion with all the panels and different angles of our collaboration. And I want to echo my colleague to say that we should do it jointly. Only jointly we can achieve these ambitious targets that we have, SDG 3.8, 3.4 and others. But also it's very important to have the partnership with all the different stakeholders, also with the private sector, young people, researchers, also with the civil society, and of course with the government. And finally, it's very important to resource mobilization. The resource mobilization should be also in the countries for their national efforts to achieve the universal health coverage and NCDs.
Brilliant, thank you. Rispa, from your perspective, last thought for the audience.
Oh, I have so many thoughts, so I'll try and summarize them. But firstly, I think I've talked about primary healthcare, so I won't say that again. But I think it's important for us to be able to sell the dream to all the people that we're working with and talking to. I think right now it's ripe for us to actually sit down across and reach across the divide more concretely, right? When we talk about breaking down those silos, it's, for instance, we've had, a comment from the floor about, healthcare workers not being here, not sitting here. And I think it's important for us to, what do we bring to the table? And I think yesterday, even at the civil society town hall that we had with Dr. Tedros, there was important reflections on how do you give very concrete suggestions, right? So I think for me, the first thing is to say, leverage that political will so you can sell that dream and you can do this together, right? So that's going to be really important. But even for countries, just work together in terms of even multi-sectoral collaboration. And I think we begin with ministries of finance and ministries of health. And then finally, again, putting people at the center. I can't say that enough. I think it's extremely important for you to make sure that that's your start. What success is not what you think success is, but what the community you serve thinks success is. That's how you achieve the dream.
Thank you. Ogti, over to you from your perspective.
Okay, thank you. We must ensure that the effort to prevent communicable and non-communicable diseases, improving lifestyle and health surveillance through to the countries. We have also recognized that the equity in paramount and ensure that everyone who eligible, they has access to cancer screening and ensure that cancer patient to get prompt treatment. Thank you.
Perfect, thank you. And Michael, over to you for the last word.
So first of all, I think this panel is quite a powerful testimony why we need more women in leadership positions, particularly in healthcare. Feel a little bit weak on this side. For me, it's very simple. It's listen, communities trust the experts, and they might not always be in your organization.
Interesting. So you've really managed to cover quite a lot of what we've talked about today, putting people at the center, the importance of community level and primary healthcare services, a joint approach, a multi-sectoral approach, the importance of partnerships, of breaking down silos, the importance of how we tell the story, how we sell the dream. The advocacy is so important. We kind of know what the answers are. There's money out there, but how do we bring these things together, and how important that advocacy message will be, and giving concrete suggestions, being really clear in our advocacy. So I want to really thank the panel for what they've brought to the conversation today, and thank you all for joining, and those of you who've joined us online or watching this on a recording 3 weeks hence. Thank you very much for joining us today. I hope we've given you some food for thought. When I asked you at the beginning whether or not you thought we were on target for achieving universal health coverage according to the targets, nobody put their hands up. There was some shaking heads. I hope this conversation has given us all some food for thought about what we can do to try and reverse that feeling and try and make a change happen. and achieve universal health coverage, because it is so essential to the global well-being. So thank you to everybody, and I hope you all have a very successful and interesting day. Thank you.